Hi, my name's Riley Lockhead, and today I'll be presenting on the breastfeeding challenge of engorgement. Specifically, I'll be discussing this challenge within the context of having twins, and will apply the situated decision-making framework to this breastfeeding challenge. The situated decision-making framework is made up of 5 components: knowledge, cues, judgment, decision, and evaluation. Our outline for today's presentation will be based on this. Today we will define engorgement, we will discuss the factors at play, we will look at the signs and symptoms, we will then go on to judgment and what is happening and determine our top 3 priorities. We will look at the treatment and management of engorgement, the nurse's role, the evaluation of the treatment, and finally conclude our main points. Although we are discussing twins today, this information can also be applied for mothers of singletons. Milk production is a normal physiological response after a mother gives birth. After birth, there is a decrease in estrogen and progesterone levels, which triggers prolactin release from the anterior pituitary gland. Prolactin's role is to synthesize and secrete milk. During this process, the woman's breast will become heavy and swollen, but should not interfere with the infant latching or the removal of milk. If this does occur, the breast may be engorged. With an increase in milk production, there is also an increase in blood supply, which can cause swelling of tissues around the milk ducts, preventing milk from being released. Milk production works within a supply and demand framework, and an imbalance between removal and production can result in engorgement. A large production of milk with little removal can cause this condition and can occur at any time during the lactation process. There are 2 types of engorgement. Primary engorgement usually occurs 3 to 5 days after birth and is due to the large letdown of milk and less removal due to the milk ducts being cut off by swelling, poor latching of the infant, or infrequent breastfeeding depending on the context the mother and infant are in. For example, are they separated due to the infant being in the NICU? Secondary engorgement happens later on in the breastfeeding relationship. For example, at 6 months, when foods are being introduced or a mother at some point decides to abruptly stop, this can also cause engorgement. Again, there can be an imbalance in production removal at any time during the lactation process, and mothers need to be aware of this. However, engorgement should be a short-term challenge, and if treated properly, subside within 24 to 48 hours. There are some specific risk factors and causes of engorgement that are related to having multiples. As far as twins have a higher demand for milk and feeding compared to a single baby, meaning a larger supply of milk coming in. Twins are usually born prematurely. This can cause latching issues due to having anatomical issues with their mouth. Prematurity can also place the twins in the NICU and separate them from the mother, decreasing the chance of having frequent feedings and skin-to-skin contact, which helps to initiate the breastfeeding relationship. For the mothers, being pregnant with multiples can increase your chances for having C-section births. Post-surgery incision pain can interfere with feeds as positioning becomes difficult and frustrating, resulting in shorter and smaller feeding times. Anatomy of the mother's breasts, such as having inverted nipples, can cause issues with latching as well. Finally, having twins in the NICU can be stressful for mothers, preventing them from being able to concentrate on the importance of hand expression and pumping to remove their milk when their infants are unable to. Lack of confidence can decrease the mother's motivation to continue and may result in engorgement. The mother will have to learn the unique needs of each infant related to breastfeeding, as they will not be the same. This can be tiring and time-consuming. Simultaneous breastfeeding may not be possible, or one infant may feed more than the other, and the mother must adjust to this. Overall, these factors explain the risk for engorgement when there is a production of milk and limited removal of the milk, highlighting the supply and demand framework of milk production. Signs and symptoms of engorgement are: breasts are firm and tender, and this tenderness can go into the armpit. The breasts are hard, shiny, and red like an apple. Nipples can become flattened, and the areolae are firm, resulting in the infant having difficulties latching. The breast may feel like it's throbbing and has warmth, and the woman may experience a low-grade fever. After looking at the causes, risk factors, and signs of engorgement, there are 3 top priorities related to addressing this breastfeeding challenge. That is, feed the infant, move the milk, and support the diet. There are treatment and interventions that can happen at each level. We ultimately want to look at if the baby is feeding well related to their latch and milk consumption, whether the mother is moving the milk, being through direct breastfeeding or using aids such as pumps and hand expression, and finally look at the dyad relationship between the mother and her infants. Treatment and management of engorgement includes applying ice packs and or cabbage leaves, which can decrease the swelling and pain in the breast. Ice packs are recommended in a 15 to 20 minute on and 45-minute off rotation between feeds. Hot showers can be helpful in expressing milk and softening the areolae in order for the infant to latch more easily. Heat can be helpful short term, but do not have heat applied for long periods as it can increase blood flow and cause more swelling and pain in the breast. Pumping and hand expression should be used in conjunction with feeds. These interventions become crucial, especially with infants that are in NICU and are not able to be at the breast frequently. Experimentation with different positions for twins will be essential. If the mother is uncomfortable, she is less likely to enjoy the feeding process and stop early. Education for the mother around what proper latch looks like will be essential. A lactation consult may be also needed. Massaging the breast while the baby feeds can also help with the milk letdown and feeding process. A proper fitting bra and one that makes the mother comfortable and manage pain should also be discussed. Some mothers find a loose bra is better and other mothers prefer no bra. Also, ibuprofen can be helpful with the discomfort and swelling. Here's a diagram to use as a reference when discussing different positions when feeding twins. This can help mothers experiment with different positions and see what is most comfortable and works best for her and her two infants. Along with providing education and treatment options for engorgement, supporting the dyad is also crucial. Letting the mother know it is normal, short-term, and fixable, along with acknowledging her concerns and frustrations, and finally advocating for the mother and infant will help in building a strong dyad. A nurse must assess the support systems a mother has access to in her community and within her home to prevent further issues with engorgement. Joining a breastfeeding group is one resource a mother can use to discuss her issues. Having extra hands at home to help with multiples would be beneficial to supporting the dyad. Making sure these resources are in place before discharge can set the mother and twins up for success in their breastfeeding relationship. It is important as a nurse to not frame breastfeeding solely as an action of productivity where the breast provides nutrients to the infant, but also discuss it as a tool for bonding. After implementing your interventions and care plan, you will want to know the effectiveness of it. First, you will look at the signs and symptoms. Has the redness decreased? Is there less swelling? Is there less pain? Are the breasts softer and the infant able to latch better? Next, you will look at the movement of milk. Is the mother releasing milk during feeds, hand expression, and or pumping? You'll look at if the infant is feeding well. Are the infants able to latch to the breast? Are they gaining weight and taking in appropriate amounts of milk? You will look at the dyad support. Is the mother and infant together as much as possible? Is skin-to-skin contact occurring often? Are family members involved in helping the dyad set up for breastfeeding? Depending on the position that is most comfortable, a mother may need help from another person to position both infants onto the breasts. Finally, you'll look at prevention education. Is the mother well versed in this challenge and able to take the knowledge to prevent and intervene in possible future engorgement issues? Does she know how to access support networks within her community? In summary, we discussed engorgement and how it can occur at any time during the lactation process, and how it is a result of the imbalance of milk production and milk removal. The factors at play were discussed specifically within the context of having twins. Signs and symptoms were also highlighted. The top 3 priorities of this breastfeeding challenge were to feed the infant, move the milk, and support the dyad. We highlighted the possible treatment and management options where the goal was to decrease swelling and improve milk removal process. We looked at the nursing role, specifically addressing not only the physical treatments but also the psychological and emotional support of the dyad. Finally, we evaluated our nursing care plan and whether the interventions were successful at addressing breast engorgement with twins. Overall, breast engorgement with twins is an issue that can be addressed in a timely manner when appropriate treatment and care are applied. Here is a list of my resources used throughout my presentation. Thank you for listening.